I'm Bomsu Kim from Seoul St. Mary's Hospital, the Catholic University of Korea. I'm going to talk in the title of Imaging Follow-up of Previously Coiled Aneurysm, When and How. I have nothing to disclose regarding my talk. For this presentation, I prepared follow-up imaging not only of coiled aneurysm, but more broadly after endovascular treatment of intracranial aneurysm, including stent-assisted coiling and flow diverters as well, focusing on why, when, and what or how to follow up. The main concerns on follow-up after coiling of aneurysm are the possibility of reopening with time. In meta-analysis by Franz et al., about 20% of patients demonstrated some form of recanalization in early imaging follow-up, necessitating retreatment in about half of them. Regarding the recurrence, several mechanisms have been proposed: coil compaction, coil penetration into the thrombus, coil migration, and regrowth of the aneurysmal sac. Risk factors may include a partial occlusion of the aneurysm, large or giant, wide-necked bifurcation aneurysms, ruptured status when treated, low coil packing density, and initial presence of thrombus. About the question how long the patients must be followed after coil embolization, there is no consensus. Some literature suggests that a follow-up period of 3 to 5 years may not be sufficient to detect relevant aneurysm recurrences, while others state that obtaining a negative angiogram at 6 months after the embolization should stop the follow-up. This is the table summarizing results of papers regarding recanalization of coiled aneurysm along the time course after treatment. In the cohort of patients studied by Sluzewski, aneurysm occlusion status changed in about 30% between the initial DSA and the follow-up at 6 months. However, no further change was reported between 6 and 18 months follow-up. Similar results were observed by Taylor et al., who compared the occlusion rate at baseline, 6 months, and 2 years after the treatment. Angiographic results between the initial DSA and the first follow-up examination changed in 28%. In 59 patients with completely occluded at 6 months, follow-up angiography at 2 years showed only one aneurysm, which was 1.7%, developed a subsequent minor neck recurrence. On the contrary, in the reports of John et al. From Seoul National University Hospital, of about 700 intracranial aneurysms completely occluded at 6 months, later recanalization was seen in 3% per aneurysm year, with risk factors including aneurysm larger than 7 mm and bifurcation aneurysm. Whereas of 65 coiled aneurysm with minor recanalization at 6 months, further recanalization to a major recanalization was seen in 17.8% per aneurysm year, with risk factors including antiplate retreatment, posterior location of the aneurysm, and second coiling for recanalization. In the report of Mortimer et al., with over 400 adequately occluded aneurysms at 6 months, in mean long-term follow-up of 31 months, 9 aneurysms, which was 2%, showed significant late anatomical deterioration. The risk was larger aneurysm greater than 10 mm or wide neck aneurysm. So, the bottom line is major change are much frequent within 6 months, and little but not a tiny number of aneurysm recanalized thereafter with certain risk factors. How about for the longer period by Franz et al., there were 2.5% late reopening in the mean follow-up of 6 years, with 0.7% of additional treatment. In the study of Sprangers et al., aneurysms with adequate occlusion at 6 months, the proportion of reopening was in 3.6%, and only one of them needed retreatment after 5 years. In the report of Jans et al., also from Seoul National, of 339 aneurysms completely occluded at 3 years, late reopening was seen in only 0.5% per aneurysm year. Yet, on the contrary, further recanalization from minor recanalization at 3 years was in 3.6% per aneurysm year, and suggested careful monitoring beyond 3 years in this subgroup. Leclerc et al. Also suggested longer follow-up because they identified significant, 12.4% of patients who had a secure aneurysm on MRA 3 to 5 years that recanalized on MRA more than 10 years post-treatment. On that, risk factors were an aneurysm larger than 10 millimeter, Raymond grade 2 aneurysm at a 3 to 5 year follow-up, and a previous retreatment less than 5 years after the first embolization. They propose that follow-up beyond 10 years is warranted in these high-risk patients. So, in the review of Sois et al., they proposed an algorithm based on main data from the literature, in that if occluded aneurysm or with neck remnant was stable, follow-up at 3 to 6 months, 12 to 24 months, and then 3 to 5 years. If the neck remnant appears or growing, a closer follow-up is done with every year up to 5 years, or with aneurysm remnant, DSA are done for discussion of a new treatment, or else without retreatment, once again closer follow-up with every year up to 5 years. And the longer follow-up thereafter were reserved for high risks, as shown before. So let me talk about imaging modalities for follow-up after treatment of intracranial aneurysm. Skull plane film is a quick and effective test, but less accurate than MRA. Compaction or displacement of the coil mass in comparison with baseline image suggests progression, and quantitative measurement of the coil mass by using skull plane radiograph has reported to have the potential to predict aneurysm recurrence in follow-up. Images on the right side is the patient with ruptured aneurysm, which was in outside the hospital, clipped at 2015 and coiled at 2018 for recanalization. Yet, the skull radiographs obtained at the last month in our hospital showed decreased height of the coil mass with compaction on the lower portion, and it was confirmed to be recanalized on DSA last week. DSA is the gold standard and is less susceptible to device-related artifact. However, DSA is an invasive procedure and has a small but not insignificant risk. Much advancement was achieved with the introduction of three-dimensional rotational angiography. Post-processing enables better differentiation between the aneurysm, parent artery, and vascular devices. However, on interpretation, it should be compared with native 2D images. Flat panel detector CT angiography is increasingly used for visualization of stent devices and aneurysm lumen analysis, allowing assessment of better wall apposition of stent along with intra-aneurysmal flow. The images are case of fusiform aneurysm classified involving V4 segment of vertebral artery. Basal CT on the left side during the treatment shows well-positioned FRED, and on the right side, DynaCT on follow-up showed obliteration of aneurysm outside the stent without instant of normality. Recently, from our early experience of volume of interest 3D rotational angiography with metal artifact reduction, it showed effective reduction of metallic artifact, resulting in better visualization of a parent vessel next to a large coil mass. Thus, it is promising to be used in the follow-up evaluation. This is the patient with a treated aneurysm with a large coil mass, and on follow-up, metal artifact was effectively corrected with MAR software with a better visualization of a parent vessel. CT angiography is widely available, low-cost method with short examination times, but imaging of coiled aneurysm is severely hampered by beam hardening artifacts caused by the platinum coil mass. Thus, CTA is not suitable for coiled aneurysm follow-up. MR angiography is once again a non-invasive method, relatively inexpensive compared to DSA, and not requiring hospitalization. MRA is without ionizing radiation and minimally impacted by coil-induced artifact. Time of flight MRA is easy to perform without contrast media. Yet, this high-resolution TOF MRA needs long imaging time, so is prone to motion artifacts. TOF MRA is also sensitive to turbulent or slow flow. Conversely, false positive results may be caused by a subacute thrombus, seen as bright signal intensity mimicking residual flow. On your right side, in the patient with giant cavernous ICA aneurysm who had treated with flow diverter, 3 months follow-up TOF MRA showed most of the aneurysm filled with bright signal intensity mimicking flow in the aneurysm, which was confirmed not to be remnant sac but subacute thrombus on DSA, and there is only a small remnant sac on DSA. Contrast-enhanced MRA is faster than TOF MRA and has less signal intensity loss related to slow or complex flow. In the meantime, CE-MRA needs exact contrast timing with bolus arrival. If not, venous enhancement can significantly reduce image quality. And also, usage of contrast media increases cost. It is restricted for the patients at a high risk of nephrogenic systemic fibrosis. On the right side, for the same patient with giant aneurysm treated with FRED in the previous slide, CE-MRA shows no artifact from subacute thrombus and clear visualization of remnant sac. For detection of residual aneurysm on follow-up, MRA showed sensitivity and specificity rates between 85% and 100% respectively, as shown in the table of 3 meta-analyses. In general, there was no significant difference between TOF and CE-MRA, and in our own experience, TOF and the CE-MRA seems to be complementary in demonstrating small aneurysm residuals. Therefore, it seems reasonable to employ TOF-MRA as a method of choice for the follow-up for simply coiled aneurysm, except for patients with stent-assisted coiling. MR in patients with aneurysm treated with detachable coil is safe. Coil-associated blooming artifacts are related to a distortion of local visual field, that is a susceptibility artifact, and also dynamic eddy currents around the coil mass, but these are likely to be minimal. The use of short TE, less than 2.5 millisecond, reduces the susceptibility artifact in the study of Spielberg et al. With evaluation of sidewall aneurysm created in dogs. Overestimation of coiled aneurysm was more prominent with longer TE. In the follow-up of aneurysms treated with stent-assisted coiling, several studies mildly suggested that CEMRA might be superior to TFMRA in these cases. This is the case with stent-assisted coiling. Both TOF and CEMRA show a segmental loss of flow signal intensity at stented segment on routine MIP reconstruction images. However, MPR reconstruction images from the source image of both TOF and CEMRA show some signal intensity in the stented segment. Therefore, one needs to thoroughly evaluate source or MPR images in addition to routine MIP reconstruction images. And also, my gut feeling is that TOF and CEMRA are with complementary information, with TOF MRA better for relationship between background, coil, and remnant because of less background suppression, and CEMRA better for visualization of parent vessel and recanalized sac, as shown in this case because of increased SNR. Recently, MR angiographic techniques utilizing ultra-short TEMRA, mostly based on arterial spin labeling, were reported to be effective in follow-up of various conditions with stent-assisted coiling and flow diversion, with much less stent-related artifact. This is a case courtesy of Professor Chung from Inje University in Busan. In a 70-year-old patient with stent-assisted coiling using enterprise stent, PATRA MR angiography shows better visualization of stented segment compared to TOF MR angiography. Also, this is published on AJNR last year. Flow diverters are made of woven threads of a chromium cobalt alloy, and depending on manufacturers may have radiopaque threads embedded. Still, the DSA is a gold standard. Yet, of the small number of reports showed usefulness of MRA, a study by Atali et al. Reported that CMRA outperformed TOF-MRA in the detection of aneurysm recurrence. Bodu et al. Reported that time-resolved CMRA is comparable to DSA for the evaluation of aneurysm occlusion after PED placement. And one thing regarding the CTA is that in the case with flow diversion without a coil in the sac, CTA may be helpful in the evaluation of reconstructed vessel. For the follow-up imaging after the PED placement, in recent reports by Gupta et al., the cumulative incidence of aneurysm occlusion by Kaplan-Meier curve did not vary significantly between the 12th and the 24th months, and it showed a plateau after 24 months. Therefore, the others proposed a follow-up imaging strategy that incorporates 12 months DSA and 24 months MRA for patients younger than 70-year-old. So, as the summary and the take-home message, on follow-up after endovascular treatment of intracranial aneurysm, early follow-up within 6 months is important. For MR angiography, TOF-MRA seems to be effective for simple coiling, and the CEMRA to be better for stent-assisted coiling, although their margin is small. Ultra-short TEMRA seems to be promising. DSA is reserved for patients with incomplete angiographic result, and interval recanalization on MRA follow-up. Thank you so much for your listening.